Welcome to Chapter 25 on thermoregulation of the older adult. The objectives for this chapter are to describe age-related changes that affect normal body temperature, age-related changes that affect febrile response to illness, and the age-related changes that affect the response to hot and cold environmental temperatures. We're going to identify risk factors that put the older adult at risk for hypo and hyperthermia. We are going to learn how to assess a baseline temperature and look at risks for hypothermia, heat-related illness, and febrile response to illness. And lastly, we will implement health promotion interventions to prevent hypothermia and heat-related illness. The primary function of thermoregulation is to maintain a stable core body temperature within numerous environmental temperatures. Normally, the core body temperature is maintained between 97 and 99 degrees Fahrenheit. This corresponds to about 36.1 to 37.2 degrees Celsius. Thermoregulation is an adaptive response that involves internal influences like metabolic rate, muscle activity, pathological processes, perfusion, amount of subcutaneous fat, hypothalamic control, and bioactive substances such as medications. Thermoregulation also involves external influences, which include environmental temperature, humidity, the type of clothing worn, and airflow. As we age, alterations in thermoregulation occur, making older adults more vulnerable to hypothermia, which is an abnormally low body temperature, and hyperthermia, which is an abnormally elevated body temperature. Normally, in cold environments, the body will utilize mechanisms to maintain body heat and produce heat. Also, a cognitively intact adult will initiate protective behaviors such as putting on more clothing or protective gear, drinking warm fluids, or seeking shelter. Physiological mechanisms in response to hypothermia include shivering, muscle contraction, increased heart rate, peripheral vasoconstriction, dilation of our blood vessels in the muscles, insulation via subcutaneous fat, and release of thyroxine and corticosteroid by the pituitary gland. Due to age-related changes, older adults have inefficient vasoconstriction. They have decreased cardiac output, and they have decreased muscle mass. They also have diminished shivering and decreased subcutaneous tissue. These are the age-related changes that put an individual at risk for hypothermia. Normally, in hot environments, the body works to dissipate heat through sweat production and subsequent evaporation, and through the ability to dilate our blood vessels to promote that heat radiation. Age-related changes lead to a higher threshold for the onset of sweating, dulled sensation of warm environments, renal and cardiovascular changes diminishing those endothelial vessel changes, and a diminished thirst sensation, which can lead to inadequate fluid intake. In disease states, these changes in thermoregulation become most apparent as the fever we normally expect in like pneumonia, for example, is absent in older adults, or it does not occur until the disease process is quite advanced. A client has an oral temperature of 99.6. What is our first nursing intervention? And we're going to go through this as the slides progress. But the first thing we're going to do is B. The older adult client has a blunted fever response and pathological processes. So a temperature of 99.6 is actually above baseline for an older adult. So we want to assess for further signs of infection. Older adults also have a higher threshold for the onset of sweating. So they won't have that natural ability to dissipate and evaporate the heat from their body. So firstly, we're going to assess for further infection. And then if there's no infection present or no risk factors or just no indication for infection, then we can remove clothing to decrease the core body temperature, which might help with comfort and further complications. Evaluating room temperature may help reduce ambient heat, and adding humidity, which is D, is actually going to make our ambient air warmer, and it's going to make our body temperature rise. Increased age is a risk factor for both hypo and hyperthermia, even in moderately cold or hot environments, respectively. In addition to old age, physiological disorders, medications, and socioeconomic conditions increase the risk for complications from altered thermoregulation. Hypothermia risk is increased by certain conditions that decrease heat production. This includes inactivity, when we have lack of use of muscles and the lack of the peripheral vasodilation in the muscles. So we have less heat produced that way. Decreased heat production can happen in the form of malnutrition. So now we don't have the caloric intake to maintain a good subcutaneous fat. It can also occur through endocrine disorders such as those that have overactive glands and sweat production or hyperparathyroidism, and neuromuscular conditions like multiple sclerosis or types of muscular dystrophy or atrophy. Hypothermia risk is also increased during conditions that promote heat loss. And some of these big conditions that promote heat loss are systemic vasodilation and sepsis or burns. Medications and alcohol can blunt shivering, induce vasodilation, or affect the central nervous system by dulling our sensory perceptions and interfering with our cognitive reasoning in seeking our protective measures against cold environments. Conditions that affect the risk of hyperthermia. Conditions that affect the risk of hyperthermia are those that increase internal heat production, like high metabolic rates, such as hyperthyroidism, and or those that interfere with the ability to respond to heat. This includes a dehydration related to fluid or electrolyte imbalances and or cardiovascular diseases. Medications can also affect the risk of hyperthermia, such as those that increase diuresis and lead to dehydration, medications like anticholinergics, which interfere with sweating, and medications like beta blockers that interfere with peripheral vasodilation. Lastly, recreational drugs that increase heat production include cocaine, heroin, and meth. Environmental factors combined with low socioeconomic status increase the vulnerability in older adults. Anyone living in an area with extreme temperature variations is susceptible to hyperthermia and heat-related illness, but the older individuals are susceptible even to moderate environmental temperature changes. For example, an older adult who exercises in high humidity will have an increased risk of heat-related illness due to an impaired peripheral vasodilation, so they can't get off the excess heat, high set points to trigger sweating, so they might not sweat and produce evaporation. The humidity in the environment is going to increase ambient air temperature, and being an older adult, there may be insufficient fluid intake blunted from our decreased thirst sensation. Social factors which put the older adult at risk are homelessness, substandard living conditions, social isolation, lack of participation in social activities, and malnutrition or diets low in protein and calories. Patients with dementia or depression may also have blunted reactions and insight to self-report problems, thus being unable to recognize and call for help in a timely manner before they fall, pass out, or have organ dysfunction. Some older adults are also at increased risk for heat-related illness due to a lack of understanding about normal temperature in older adult patients. For example, if we assume no infection is present because of a lack of a fever, we might not diagnose it in a timely manner before multi-organ failure sets in. Healthy older adults in safe and comfortable living conditions will have no functional consequences of altered thermoregulation. However, when the risk factors are present, hypothermia or heat-related illness will develop quickly. A recent meta-analysis showed that a decrease or increase in 1 degree Celsius in temperature was associated with increased risk for cardiovascular and respiratory illness and mortality. In a Medicare review, most hospital visits were attributed to hyperthermia, but it was hypothermia that actually had a higher mortality rate as well as increased hospital admission and longer stays. In hypothermia, the older adult is more at risk because they're less aware of a low core body temperature. They're less efficient in their physiological responses to cold, and they're less apt to take corrective actions when necessary. In early stages of hypothermia, the older individual may not shiver nor feel cold, thus allowing hypothermia to progress rapidly. Once the core body temperature falls to 93.2 degrees Fahrenheit, myocardial effects will set in and cause death. In hyperthermia, the older adult is at risk due to delayed or diminished sweating and decreased awareness of environmental temperature. Hyperthermia can occur as either heat exhaustion, which is gradual and usually develops from dehydration, or heat stroke, which is a more serious complication, and it's due to an inability to balance heat production and dissipation. When heat-related illness is not reversed, death ensues due to respiratory depression. Age-related changes in the hypothalamus diminish febrile response to infection. Thus, infections go undetected until they progress or manifest as a change in mental status. Compared to baseline, however, the older adult may actually have a slight increase in core body temperature, but we as nurses don't register it as a fever, and neither do the numerous information technology systems like Epic, because it's not flagged as that low. Altered perceptions of environmental temperatures are attributed to cardiac insufficiency, dementia, or thyroid disorders. If thermoregulation of the older adult is not recognized, the risks for hypothermia, hyperthermia, or unintentional misdiagnosis of infection may progress quickly to severe ramifications of altered mental status, functional decline, and/or death. Nursing assessment for thermoregulation focuses on establishing a baseline body temperature, identifying risk factors for altered thermoregulation, and recognizing manifestations of hypo or hyperthermia and febrile response to illness. We should record temperature at different times of the day for several days when the patient is feeling well. We want to note that older adults will have a baseline of a lower body temperature, especially when they're sleeping, but they'll still show fluctuations during pathological processes. It is prudent to note then that small elevations above baseline can be an indicator of the presence of infection. While identifying and assessing for risk factors, note medications and medical history. Assess the socioeconomic status of patients. This might reveal environmental risk factors for both hypo and hyperthermia. When assessing for hypothermia, compare our temperature against the baseline. A hallmark of hypothermia is cool skin in unexposed areas, such as a cool abdomen. Early hypothermia may show an uncontrollable shivering, but as it advances, there will be a lack of shivering. Severe hypothermia will advance to the point of muscle rigidity, cardiac arrhythmias, and death. When assessing hyperthermia, again, compare that temperature to your baseline. Early signs include weakness and lethargy and a possible headache. As hyperthermia progresses, our skin becomes dry, warm, because our sweating is absent. We have vasodilation, hypotension, and death. In assessing the older adult's febrile response to illness, remember that the temperature increases will be subtle, so assess for other signs of infection, such as a change in mental status. Usually, an increase in 2 degrees Fahrenheit or higher in older adults would indicate a febrile response. Also, I just want to add, when we're assessing for hypothermia, make sure that the thermometer registers below 95 degrees, otherwise we might miss those very low temperatures. Nursing interventions then are aimed at the individual setting. For example, in acute care, our interventions are focused on systems and immediate physical conditions like vital signs, cardiovascular maintenance, and hydration. In long-term care, nursing interventions focus on the ability of nursing and healthcare professionals to identify infection against a baseline. In community settings, interventions should focus on the recognition of risk factors for both hypothermia and heat-related illness, especially during times of extreme weather conditions. Older individuals usually prefer an ambient temperature of 75 degrees Fahrenheit. Thus, when we're addressing risk factors, a steady environmental temperature is the most important intervention to prevent hypothermia and heat-related illnesses. In promoting healthy thermoregulation, nurses should ensure other environmental interventions are accommodated, such as having protective clothing, air conditioners, and maintaining overall optimal health actions like maintaining adequate hydration. Caregivers also need to be aware of the changes in thermoregulation of the older adult so that they don't, again, miss signs and symptoms of infection, and that they can maintain adequate environmental standards to reduce the risk of hypo and hyperthermia. One more question. What is the best way that a nurse can assess baseline temperature in an older adult? The answer here is C. To assess baseline temperature, assess the body temperature at different times of the day for several days while the client is feeling well. Document our diurnal variations, such as lower temperatures with sleeping, and use the same thermometer and method for each temperature recording. Thank you. Oh, actually, I have one more slide. There it is. Any questions? Let me know. Thank you.